All right, folks, I wanted to make a quick little video for you guys based on one of the common questions that have come up on our YouTube channel. Please keep on having these questions come up on our website as well as on the YouTube channel as well as other social media. I love to be able to pick the ones that I think are going to benefit all of us and be able to share with you my thoughts on them and get your feedback. And so we can have this kind of a back and forth in terms of what is the best thing. As we know, the science is not settled in many of these areas in our field. And so it's important to have a conversation about these areas and be able to put our collective wisdom together and come up with decisions that are best for all of us at the end of the day. So this one is by Dr. Ahmed here, and he asks, Dr. Nasseh here, I had a patient that had apexogenesis, a young patient, and the apexogenesis was successful. As you can see, we have a tooth that has incomplete root formation. It was a 9-year-old female patient, and in 2018 had the apexogenesis done. It seemed to be working well. And then when the root formation was complete, the endodontist recommended that, but maybe now we should do a root canal to avoid calcification. And the question is, well, is really root canal necessary? And I think that's really a great question, because we oftentimes see this being said that following apexogenesis in teeth that have open apices, and then you get the full formation of the root, in order to avoid full calcification of the root, maybe we should do root canal therapy preemptively. And while we could argue about the merits of doing such action, I think it's also important to kind of put things in perspective and say, well, what do we really have to lose by having a proper follow-up protocol on patients like this, so we can maybe find out whether they absolutely need the root canal or not. Because don't forget, devitalizing the pulp is not necessarily a just-in-case scenario. We should really do that if it's really necessary, since it has its own set of risks in terms of failure, and the later we do that, it would be better if possible. Of course, it's a great and proven procedure, and by all means we should try to avoid necrosis, because we know that once pulps become necrotic, the success rate drops down a good 8 to 10%. So we don't want to wait till pulps become necrotic before and a biofilm is established before we do root canal therapy. But then at the same time, if we are able to communicate with our patients, or in this particular case with the patient's parents, and then emphasize the importance of proper follow-up, then we might be able to just do a routine follow-up for this patient, monitor the activity of this tooth, and if we see that necrosis is about to happen or full calcification is about to happen, then root canal therapy might be indicated preemptively. But just to do that as a routine, in my opinion at the present time, it is probably not really indicated. So we need to kind of go back and understand that, again, like I said, we want to avoid necrosis, and we also don't want to do root canal therapy on fully dystrophically calcified teeth. Although, if it's fully dystrophically calcified, you could make the argument that maybe nature did its own root canal, but oftentimes these teeth end up having aesthetic problems, especially in the anterior area. But in this particular tooth, being a premolar, it's not necessarily an aesthetic area. So we do have, again, more of a chance to follow up with this patient and see where things end up. And it really is our responsibility to communicate with our patients the importance of proper follow-up, so that we can have a more predictable kind of outcome, and also know in cases in which further treatment such as revisions or epicoectomy is needed, by explaining to our patients that root canal therapy is not complete the moment we're done, but it's a process by which we need to kind of have follow-ups to make sure things heal and infections don't reoccur. And that's an important part of our duty to our patients, especially in light of some of people's beliefs about, the festering of infections associated with root canal therapy and so on, which is really a function of people not doing follow-ups. Really, that really is what it's all about. But anyway, let's also talk about what are the mechanisms in which you do get dystrophic calcification in these types of teeth where you do apexogenesis, such as this case, which was successful and it did very well, or in cases in which you do revitalization and regeneration and then you end up getting calcification. One of the current theories on that front is the persistence of an inflammatory basis that makes the calcification continue despite the formation of the root, and that is generally due to inadequate or incomplete removal of caries. As you probably know from my previous videos, I do believe that we do need to remove all caries completely, even at the expense of pulpal exposure. I'm not one who's for selective caries removal or indirect pulp capping. I believe all caries should be removed, and that we can then do direct pulp capping if necessary. But either way, in this particular case, it's important to understand that apexogenesis, especially in younger patients that have a juicy pulp, can be very successful because the larger the pulp, the higher the chances, and especially in younger patients, due to adequate perfusion and the presence of adequate stem cells, for the pulp to stay vital and to recover from these types of capping procedures. And then you get the completion of the root formation, so you have a stronger root. And at that point, I really see no reason to merely do root canal therapy in anticipation of the pulp going necrotic. I don't think we have any studies that show what percentage of these teeth go necrotic, but we do know that if you have caries left behind, then you get more and more calcification. So that's what I was trying to say. All right, guys, so it comes down to this. My recommendation in this particular case is not to do root canal therapy preemptively. Number two, to have a rigorous follow-up regimen for these types of patients, 3 months, 6 months, 1 year, and then 2 years on a yearly basis, up until 5 years, to make sure everything is healing well, and keep an eye on the tooth. This way, hopefully you can avoid root canal therapy and the tooth can remain vital, which is, as I've mentioned many times before, the pulp is the best root canal filling material. So with that, don't forget to subscribe and leave comments below. I love to kind of read these comments and be able to share with you the ones that I feel everyone can benefit from by going into a little bit more detail. Until then, for Real Dendo, I'm Ali Nasei, and let's save some teeth. See you in the next video.